My name is Lise McDowell. I'm with Norellis Pharmaceutical, and I have the pleasure of introducing Dr. Rajaraman.
Okay.
I don't usually call him by his last name, so my apologies. He's a pediatric epileptologist at UCLA, and as you know, he's going to be speaking on difficult to treat epilepsies, and that's next. Thank you again for participating, and hand it over to you.
Thank you.
Hi, everyone. It's a pleasure, and thank you, everyone, for coming. So I'm Raj Rajaraman. I'm a pediatric epileptologist, which just means I did neurology, and then I did fellowship training in epilepsy, and then pediatric epilepsy. I specialize in rare genetic epilepsies and difficult to treat epilepsies. I direct the Tuberous Sclerosis Center of Excellence. Tuberous sclerosis is also a pretty rare genetic epilepsy, and then I direct the CDKL5 deficiency disorder clinic, which is even rarer epilepsy. I am the primary investigator for over 10 clinical trials for different medications, and I'm here to kind of help and answer questions, but I'll do some PowerPoint stuff, and then if you guys have any questions, please interrupt me while we're talking. It's very informal. Just speak loudly so I can hear you, and then we'll go from there. So just so everyone's on the same page, what is a seizure? Because I feel like sometimes people don't talk about what technically a seizure is. And a seizure is a sudden surge of abnormal electrical activity in the brain, which causes the seizure. And just because you have one seizure doesn't mean you have epilepsy. You need to have 2 or more unprovoked seizures. So going back to the top. So a seizure is abnormal electricity, right? So the EEGs that people get measure your electricity and your brain waves and looking at the different electrical activity going on. So all the medications, everything we're doing is trying to control the abnormal electrical activity in your brain. Now, just because you have a seizure doesn't mean you have epilepsy. So let's say you have a febrile seizure, you have a seizure with a fever as an infant, that makes it less likely technically to be epilepsy. That just means you have a febrile seizure. If you start having seizures which aren't provoked, it's not from a cause like a fever or something that we know, then we start saying you have epilepsy. Very common, about 1 in 26 people will have a seizure in their lifetime. 3 million people in the US will have epilepsy, 65 million in the world, and more people live with epilepsy than autism, Parkinson's, and MS combined. So, everyone's here for Epilepsy Day at Disney, but we know this is a very, very common problem. So you're not alone. You're here at Disney Day. There's a million resources here. A lot of people here who are invest in epilepsy and want to help. This is a UCLA team. We walk at the Rose Bowl every year, part of the Epilepsy Foundation, Greater Los Angeles. So a really awesome walk. UCLA participates in that, and that's run by the Epilepsy Foundation. We participate in Disney Day, which is ran by Brad and Candace. So it's part of kind of a network. So people you meet today, always stay in touch with them, keep things close. So the question is, what can cause epilepsy, right? So there's some major things. So there could be something structurally wrong with the brain. At that point, we recommend getting an MRI or getting imaging to see what the brain looks like, to see what is abnormal. Next, genetic causes. So if the MRI of the brain doesn't show a clear explanation, we definitely recommend getting genetic testing. And with genetic testing, we have multiple types of genetic tests. So one is called a chromosomal microarray. Now the microarray it's a specific test, and what it does, it looks at the chapters in your genes. So the epilepsy gene panel looks at specific genes, so like 1 gene or 2 genes. The gene panel looks at like the whole chapter, see if something's copied or deleted. It looks at bigger chunks. So The microarray is a good first step to see if there's like a chunk missing or duplicated or deleted. Please go ahead.
Is it possible to have both a structural and genetic cause? Can that be two
Yes,
things?
yeah, absolutely. So tuberous sclerosis, with one of the genetic syndromes that I take care of, they have a genetic mutation. It's called the TSC1 or 2 gene. And that gene causes the epilepsy, but also causes changes to your brain and causes abnormal tumors in the brain. So you can have a genetic cause that can make a change to the brain itself. But a very good question. You can have both. Any other questions up to here? Please feel free to ask. So the genetic testing we recommend usually get a chromosomal microarray. So that looks at the chapters to see if there's like a big deletion or a part that's duplicated. Let's say that's normal. Then we also want to look at specific genes. So there are about 300 genes that we know cause epilepsy, just at this point, probably more. And there are panels where they test the top 300 genes. And they look to see if there's a mutation that can cause the epilepsy. Now, when we get the testing, we usually say test the parents too, because you want to see if it got inherited, if something got transferred, or is it just something brand new that happened when the egg and the sperm came together and made the baby. So we check the parents, we check the patient who's having the epilepsy, and we want to make sure it's one of the top 300 or so genes involved for the epilepsy. So we do the microarray, then we do the gene panel, and then next is exome sequencing. So whole exome sequencing is where you look at all the genes. And you're trying to see not just the 300, but the 1,000 genes. Is there anything that's mutated, deleted, that can cause the epilepsy? Now we do the MRI, we do the genetic testing, but sometimes it's still unknown. So we can say it's likely genetic because we don't discover all the genes yet that can cause epilepsy. So 6 out of 10 people with epilepsy have an unknown cause, but that it's unknown right now. We just haven't figured out yet exactly what gene or what is really happening causing the epilepsy. So let's say you had genetic testing done like 5-10 years ago. We recommend you repeat it because new genes are discovered. And just because it wasn't discovered 5-10 years ago, it could be now known, and then you repeat the testing to find out more. So this, what causes epilepsy? So structural, genetic, and then often unknown. Any questions up to here? Okay. Yeah, go ahead, please.
Has there been any kind of movement to encourage more people to get genetic testing so that, like, even people without epilepsy, like, if they may develop it in the future, just so that, like, right now there's 300 known gene variations, like, there could be, who knows how many more. Is there any attempt to discover that in the general population?
Yeah, so that was a very good question. So most insurances won't cover genetic testing unless you have the disorder. So if you have seizures, then the insurance companies will most likely cover it. So that's kind of one big part of it. The other thing is sometimes genetic testing will tell you things that maybe you don't want to know or things that haven't happened yet. So when we do genetic testing, everything has to be done with a genetic counselor to explain what the results are and what it means for you. So we don't do like whole exome or do a whole genetic testing on everyone who comes through the door because sometimes we don't know what to do with the results. Sometimes you can have a mutation, but that doesn't mean you're going to have the disease. So like I could have a mutation that's in the epilepsy gene, but I don't have epilepsy. So that doesn't really mean I'm definitely going to have epilepsy in the future. I just might have that mutation. So it's not always proven 100% that just because you have the mutation, it doesn't really mean that. You need to have symptoms first as well.
Would it be beneficial to know, like, if you're going to pass that on to future children?
Yeah. So let's say someone has a child with epilepsy and the parents get tested, and let's say they have the same genes, that lets them know about future testing and future things to do. When people try to have a baby outside of even epilepsy, there are genetic testing that is done when you're pregnant just to look at very common medical problems that can occur to the baby. So often during pregnancy, there's genetic testing done anyway. So there are causes by age too. So babies, very common causes are genetics, sometimes infection like meningitis, other kind of brain infections. There are birth injuries, so sometimes the baby's deprived of oxygen and you can have an injury then. There's genetic things like TS and autism, other kinds of causes. So autism, epilepsy are very closely connected. About 1/3 of kids with autism will have epilepsy too. So there's a big overlap. Now let's say you didn't have seizures as a baby, but in adulthood you start having seizures. So you could have something genetic that just showed up when you're an adult. You can have a head trauma, so some people get in a car accident, they hit their head, it's a pretty bad injury, and then you get seizures from that injury. We have people serve in the military, they get a head injury, and then they'll have epilepsy afterwards. Strokes can cause seizures, tumors can cause it, and also unknown. So kind of based on your age and your history, that lets us know what kind of testing we should do. So that's what causes epilepsy by age. What do we like to do? So we get a history, a physical. We usually do an EEG to look at the brainwave patterns because that can help us figure out more about your epilepsy, the imaging, and then the genetic testing, which we covered. There's like 3 major types. Okay, so how do we treat epilepsy? So the first one is medications, right? So, and with medications, we've had over 100 years of anti-seizure medications from the early 1900s all the way to new drugs coming out this year. And the important things about new medications is that new meds treat your seizures from different mechanisms than the old ways. So some drugs treat medications one pathway, or they work on the pathway in one way, but newer drugs have a different mechanism of action. So a drug like phenobarb works on, let's say, GABA, which is one class, but then if you go on, there's other medications that work on different classes. So some of the newer classes have less side effects. And also, if you have difficult to control seizures, it's good to try medications in different classes. Because you don't want to repeat the same class over and over again, because you're kind of just sticking with one group. So your neurologist would probably want to try different drugs from different classes to attack the seizures from different angles. Does that make sense? Right? So there's new medications with less side effects, and they work with different mechanisms of action to attack in different ways, which is really important because there were periods of time where we were kind of low on medications, and now we have over 30 medications, and they all work differently. So it's important that just because you failed certain medications doesn't mean continuing doing medications won't help. So if you're still having seizures after 2 appropriately well-dosed medications, then you're considered to have refractory epilepsy. And so we say 2 medications. So this is the Pediatric Epilepsy Surgery Alliance. They gave me this button because after 2 meds, then you're considered intractable, and then you're hard to treat epilepsy. So what do you do at that point, right? So just show of hands, is everyone here with their loved one or family on 2 or more meds and trying to figure out the next steps? Okay, so pretty much everyone, okay. So after that point, you should be referred to a level 4 National Association of Epilepsy Center to be evaluated on whether you can have surgery to stop your seizures. So after 2 meds, it's really important to see if you can have epilepsy surgery to improve your seizures and try to get rid of them. Go ahead.
Is UCLA level 4 national?
Correct. Yeah.
Is UCSF?
UCSF as well. Yeah. They're correct. Anybody been evaluated for epilepsy surgery here? One person. Okay.
We didn't go to a level 4 though. She just did it on her regular enrollment.
Sorry?
We didn't go to a different.
Okay.
We didn't go to level 4. He just recommended it from there. So she
Okay.
didn't be in it.
Yeah, Vietnam surgery. Okay.
Do
So,
they do anything different at a level 4 before they recommend you for surgery, or do they try anything else?
so we usually do different testing. You might have had testing with that neurologist, but when I get that slide, you tell me if that was done. So, before I get to surgery, so clinical trials is also really good. Yeah, sorry. Level 4 means that you have the capabilities to do epilepsy surgery, like cut out part of the brain. And also level 4 centers does the additional testing that will let you know if you're a candidate for epilepsy surgery. So they come in different tiers, and level 4 just means we're at a tier where we're comfortable and we do epilepsy surgeries a lot. Okay. Before I get to surgery, I meant to clinical trials. So let's say you try medications, but you have a certain epilepsy disorder, like tuberous sclerosis or something else. There's like lots and lots of genes, or you have really controlled epilepsy. There are clinical trials which will give you exposure to the newest medications. And what is the benefits, pros and cons of doing a clinical trial? You get access to new drugs with possibly less side effects for free. That's meant for your disease. So we study certain drugs with tuberous sclerosis, and we say, okay, this drug might be really helpful for TS. You can try the drug before it's on the market. You can see if it's beneficial. It's free. The companies pay for your travel and everything else, and then we try the medication. If it doesn't help, you always just leave the trial. It's nothing mandatory. If things don't help, you just leave. So that lets us know if the drug is helpful. The families get to try the medication, and all that is kind of positive. You get close monitoring. Cons is, one, it's a time investment to do a clinical trial. You have to go to the hospital or the site multiple times. You have to have close monitoring. There's a lot of conversation with your doctor. Initially, you could be placed in a placebo group. So one group is no medication, but we don't know it. The doctor doesn't know. You don't know. No one knows. And it's like that for about 2-3 months. And the reason why is because we want to make sure that the drug is really helping. Because if you just get the drug, almost everyone will have some benefit, but you really want to know compared to people who think they're getting a drug, but it's not really helping the brain. So that initially in the beginning, you might be in a placebo group, but eventually everyone gets the drug. So there's a little bit delay in getting the medication. There might be unknown side effects, and also might not help. So the clinical trials are a good option if you have difficult to control epilepsy, to see if there's new meds that are really specific for your disease that could really help. Okay, so for epilepsy surgery, and what we do for epilepsy surgery is that if you have one part of the brain that's causing your seizures, let's say it's the right temporal lobe in this case. If the right temporal lobe is causing the seizures, and they're all coming from that area, we do testing, and then we decide, is this part causing seizures, and then we cut it out. So the epilepsy surgeon does actual focal resection and cuts out the part of the brain that's causing seizures. So this is before, and this is after. You see this part of the brain was resected, and it stopped the seizures afterwards. So if you fail 2 medications, it's really worth being evaluated if you're an epilepsy surgery candidate to see if one part of the brain could be cut out to stop your seizures. So what do we do at UCLA? So we do first a video EEG, and we want to capture multiple seizures on video EEG to see if it's coming from one part of the brain. Now let's say we capture 3 seizures. One is coming from the left side, one's coming from the right side, third one is like all over. Then it's really hard to say, okay, your seizures are coming from one part, which makes it less likely to cut out that part, right? But let's say we capture 3 seizures and they keep coming from the left temporal lobe. And we say, okay, everything's pinpoint on the EEG to that, the left temporal. Let's do the MRI scan. We do the MRI scan, and it also again points at the left temporal. So you say, okay, the EEG, the MRI, all points on one part. We do a PET scan. So a PET scan looks at sugar metabolism. And let's say a part of your brain is low in sugar metabolism. That means that part of the brain isn't working right because you're not metabolizing sugar in a normal way. So it's low in that part. So you do the EEG, the MRI, the PET scan, everything's just pointing to one part of the brain. And we say, okay, this looks like you really could be a good candidate for epilepsy surgery. There's additional testing, a MEG scan, a SPECT scan if you need it. to give more evidence that this is the one part where it's coming from. Now everyone's worried about epilepsy surgery. What's the cons, right? So the con is a part of my brain that's important that I need, or will it affect me long term? So we do something called functional MRI testing. So functional MRI looks where your motor function is, looks where your language is. It pinpoints the part of the brain where really important things are. We do neuropsych testing to see where your memory is. We do other tests to see, okay, where are the important parts and which parts are less important that we could cut out, and you'll have a minimal effect to your cognition or your function. We do all the testing, that we present this to a comprehensive meeting. So it's the epilepsy docs, the surgeons, the radiologists, the psychologists. Everyone's all together in a group, and we go over the case, and then we say, okay, will this person benefit from surgery or not? Or what are the chances of being seizure-free? What are the risks? What are the pros and cons? And then after that, I come back and I talk to you about what are the pros and cons with the surgeon. So just because you have the evaluation doesn't mean you're signing up for surgery. All we're doing is to see if you're an epilepsy candidate. Then we start having the important talks about whether you want to keep going and do the surgery and the next steps. It's a bit of a slow process. It's a lot of testing, a lot of talking. But the goal is to really see, can we do something surgically for you? So this is the epilepsy surgery, the resection part. Any questions about this? Yes?
Do you guys do the laser ablation surgeries?
Yeah. So the image that I showed you was they open up the skull and then they cut out the part. If the part is small enough, you could do a laser. You put a laser in that area, and then you kind of send the heat to melt that region. So it's a lot easier because you're not opening up the skull. You go home the next couple days, you just take the laser out after heating up the area. When can you not do a laser? Is if the part which is causing seizures is too big. So the laser only has a certain amount of perimeter in order to heat up. So if it's too big, then it's sometimes not worth doing the laser. So the discussions of what kind of surgery technique is also considered. Yeah.
Are there any available surgeries for patients with generalized epilepsy?
Yeah. We'll get to those ones too. Yeah. Yes. You say that one more. What is the neuropsych testing for? So the testing looks to see, is your memory affected? So let's say your seizure coming from the left temporal lobe. And the left temporal lobe is involved with like verbal memory, like remembering names and stuff like that. So let's say that part's really affected. That says, okay, you have trouble remembering names, then that points towards your left temporal lobe where the seizures were coming from on the EEG. Let's say your visual spatial, so you remember like pictures and images, but the seizures really affected that, then we'll say, okay, maybe it's coming from the right temporal. Or let's say your seizures coming from the frontal lobe, but you have a lot of like executive function issues. So the neuropsych testing points to parts of the brain where we think the seizures are coming from. Yeah. Okay. If epilepsy surgery is not an option, we have other therapies. And I'll get to the epilepsy surgeries for generalized seizures in a bit. So diet therapy. Has anyone been on a diet therapy here? Yeah, okay. Ketogenic diet? Yeah. Okay. Has anybody not heard of the diets? Okay, everyone's pretty good. Okay, so in terms of diet therapy, there's kind of three main ones. One is the ketogenic diet, which is the standard classical diet, which is high fat, adequate protein, very low carb diet. And there have been studies where people have been placed on these diets, switched off the diet, put back on the diet, and has been shown to help reduce seizures. What's the pros and cons of a diet? One, it's not a medication. It doesn't affect your body in terms of like side effects like sedation or things like that that you can get with medications. It's a little more natural. It is a diet therapy. Cons is that it's very strict diet, so you have to really adhere to the diet. You have to drink plenty of water. You have to really kind of stick to the meals and regimens that are provided by the ketogenic diet team. So it's a little bit hard to, let's say, go to school and you eat like a chocolate chip cookie or something like that. That will totally mess up your diet and not make you ketotic, which is our goal. Now, if the keto diet is too strict, there's something called a modified Atkins diet, which is less strict. Some of our teenagers, adults, are more comfortable with that because it gives you a little more flexibility about the type of meals that you want to try. But it's still a very strict diet. It's stricter than everyone else's regular diet. And low glycemic is the one with the least amount of evidence for, but it's also effective for epilepsy. So, in the classic ketogenic diet, 90% fat, 6% protein, and 4% carbs. Modified Atkins, you go from 90% to 65, and then low glycemic to 60. So, yes?
Right. Earlier you mentioned that the PET scan looks at the sugar metabolism. Would that be an indicator whether one of these diets might be effective?
No, yeah. No, it's a good question, but that won't help us with that. But there are certain genetic syndromes where keto is the treatment of choice, but those are pretty rare epilepsy disorders. Charlie Foundation, I don't know if they're here today, but Charlie Foundation is they're a really good website for the ketogenic diet. It talks about different recipes, what you need to get evaluated, treatment options, and it's a good resource. And if you want to get evaluated for the ketogenic diet, so good option outside medication. We often don't need it, we don't try it early enough. You need constant supervision with a dietitian and neurologist because you want to make sure you're staying ketotic. You want to make sure your labs are good, that you're staying on your food. We recommend trying it for at least 3 months to see if you have any benefit because usually under 3 months you won't see any change. So it's more of a long-term treatment, lifestyle change, or lifestyle modification to see if you can get benefit. Breaking the diets like skipping medication doses, you kind of have to really be invested. Any questions about keto? Yes? So her question is that if you're on the keto diet, do you have to stay on other medications or can you just stay on keto? So usually you are on medications initially, you go on keto. If you're seeing a really strong response to ketogenic diet, we start lowering other medications. Now there are people who have been seizure-free on keto, who have totally had a 100% response. Then sometimes we are able to get off all meds. It's less common, but it's definitely a possibility. Okay, so devices. So there are 3 devices that are kind of FDA approved now for epilepsy surgery. So the VNS, that's the vagal nerve stimulator. That device gets put under the skin right here. There's a wire that goes up to the neck, and this is the vagus nerve. And the wire goes on that nerve, and then it sends a pulse up to the brain. And the pulse to the brain is supposed to try to stop that abnormal electrical activity to come together and make a seizure. So seizure is just abnormal brain waves and electricity. These pulses of electricity are trying to stop the waves from coming together. So you're just kind of breaking things up. What are the pros and cons, of course, with a VNS? So pros, it's not a medication. You're not worried about sedation or appetite issues or any kind of side effects you might see with medication. It's a different way to treat other than the meds. It's actually, out of the surgeries, it's pretty quick. You can do it in an outpatient surgery center. They just put it in and you go home the same day. One of the cons is that there's a cosmetic scar like here and then a scar on the neck. It fades with time, but there is a small scar. It's a device. in your underneath your skin. So if you're going through the airport or any kind of things like that, you have to notify them, hey, we have a device. The cons is that it's sometimes difficult to be 100% free, 100% seizure free on a VNS device. There are people where it does be that effective, but it takes time for the device to really kick in and help. So we like to say at least a year of the VNS working and trying before we have a good idea about how effective the VNS is. Now there are some people where the device doesn't help at all. There's some where it helps a little, there's some where it helps a lot, and there's some where it totally stops them. I can't predict which group you're going to fall into, so it's kind of like a medication sometimes where we don't know the full effects. So definitely a good option though. The other one is called the responsive neurostim, and the RNS device is this one over here. And what does this device do is it's used for two options. One, it's used for surgeries where you can't cut out the part because the part's too important. So let's say your seizure is coming from language and you don't want to cut out the part, which helps with language, of course. So this device gets put in the skull and then the electrode goes in that part of the brain which causes the seizures. And then it's kind of like an EEG, which you walk around, it will record your seizure activity. And then it will recognize the seizure activity and then send a stimulation to try to stop it. So the VNS doesn't record seizure activity, but this device does, but it's more invasive. You have to open up the skull, put the electrode where the seizures are coming from, put the device in the skull, and then close it. So more invasive, but it treats specifically where the seizure is coming from and has an EEG device to record what it looks like. So it's not sending a signal all the time. It's trying to capture what the seizure looks like and then send it.
Dr. DNS,
Yeah.
when you have it, over time, will it try to correct like the abnormal brain waves to make them more normal, or is it just ultimately kind of stopping them, the abnormal brain waves?
Yeah, so not fully the first one, but it does show improvement over time. So there's a thought that maybe there is a neuromodification part to it because there's people who are still seeing response years later and not seeing the initial response that first year. So we think there is a modification. As the goal isn't just to put it in and see if it clears up your abnormal activity in a year, but there are improvements as time goes on. So we think there is a modification to it. Yes?
These devices all have batteries, is that
Correct.
correct?
Yep.
How often do the batteries need to be changed? You have to go back in?
Yeah. So it depends on how much energy is being given. So some VNS devices, some of the doctors turn up the energy really high because you have a lot of seizures and you're really trying to reduce them. Sometimes those you have to change within like 3-4 years. On average, I would say between 5 and 8 for all devices. I think that's a relatively good average. But yes, at a point you do have to switch out the batteries or the generators. The last one is deep brain stimulation, where again, you attack the seizures, but you're putting the electrode in the part of the brain deep where the thalamus area, which is kind of the relay station for seizures. So your seizures go through that area of the brain, the thalamus, so you're stimulating that area to kind of stop the seizures from relaying through. So the VNS works on the vagus nerve, but the DBS works on the deep structure. And that one is, again, a surgery where you have to implant a device in the brain, but you send electricity that way too. Another time for the RNS is, let's say you have seizures coming from two parts of your brain. So let's say you have seizures from the left frontal and then the right temporal. It's hard as you can do it, but it's sometimes hard to cut out both parts of the brain. So you put a device that puts electrodes in both parts, and then it records and sends a signal to try to stop that seizure. So RNS is a good option if you have multifocal seizures, meaning coming from both parts, two areas, or it's coming from a part where the brain is eloquent and we don't want to cut it out. So those are 3 devices. There are also, yes, please.
For RNS, what's the age? Like how young how
I think it's approved for adults and above, but Off-label, we have definitely done implants and treated pediatric cases.
Our son got VNS super young, like
Yeah.
under 2 years old.
Yeah. So VNS, all these devices off-label can be implanted if the center is comfortable with it, and also you just want to make sure you have insurance coverage for it. Yeah, because there are times where we try to implant something, there's a lot of back and forth with insurance, and you don't want to be stuck with that. So, yeah. But yeah, we do have very young people with RNS too. So these are the devices. Are also, yes, go ahead. Can someone repeat the question?
Do you ever do device? Let's say someone has device and seizures have to be cleaned out, but
Yeah.
still not zero. Do you ever
Do I start another medication later? Yeah, sure. So let's restart the device. Seizures really help. Sometimes we start lowering other medications, getting rid of them, or we try a new medication, replace your old one, to see if that's just a little extra we need to get you over the hump. There are other epilepsy surgeries that I didn't mention. So there's something called a corpus callosotomy, which is kind of resecting the relay between the two hemispheres of the brain. Those are really helpful for drop seizures. If you drop with your seizure, sometimes the highway, if you do the resection, that will help. There are larger surgeries called hemispherectomies, where you actually take out the whole half of the brain, which is causing seizures. We do that a lot at UCLA. We've done it for as young as like 3 months, 4 months old, because one part of the brain is severely affected. So there are a lot of different epilepsy surgery options too. So we covered the medications, we covered the clinical trials, we covered epilepsy surgery and the different types, we covered the diet therapies, we covered the devices. If you're interested in epilepsy surgeries, there's the Pediatric Epilepsy Surgery Alliance, the PESA out there. There's keto teams, we have a UCLA booth. If you guys have any questions, I'm here, so thank you everyone.
So the VNS, you
Yes.
said they can change the voltage, I guess, the amperage and stuff. Is there places that you can go with that where it doesn't help and taking it back down or going back up? I mean, how do you determine where you need to go?
Yeah, so the output current, just from the trials and just experience, you reach a certain point where you don't get as much return by keep going up, and you just start running into side effects. So on really high currents, you can sometimes get like a scratchy throat, or you feel it, like zap. You're never supposed to feel it, or you feel like you have like a weird swallowing feeling. That's usually at higher currents. So if the patient's feeling that, or you notice while they're eating, they're making weird noises, then you usually just lower it. Especially if you don't feel like it's going to help.
So if they've been on it for a while and it seems like it's doing well, and then you have where it looks like it's not working as well, I mean, is there changes still going on in the brain if they're not an adult yet?
Yeah, absolutely. Yeah. And then sometimes you have to change other settings. Sometimes you want to make it go off more often, or you want to change certain things. So it doesn't necessarily mean how strong you put the current, but there are other things you can change.
Okay.
Also, if it's been working really well, all of a sudden stops working, then I would suggest checking the battery, make sure it's not out of juice.
So, she just had this done.
Okay.
A couple months ago. So we're still in the process of the every 2 weeks.
Correct.
Well, we just finished that.
Yeah.
So that very last 2 weeks,
Yeah.
and then we go back a month. That very last 2 weeks, we turned it up.
Yeah.
When we turned it up that last time, she started having seizures every day, all the time. And so he said they're really going through that.
Yeah.
So is there a point, because I mean, he says either way, we have to get her to like a standard baseline.
Yeah.
So most people do the best.
Yeah.
But is there some people that can't get there because if they can't handle it, can it make it worse?
Then I suggest you just do longer periods of time in between the increases.
Okay.
So if she's like not, if for some reason she had a lot of seizures now, maybe just go back to the last step, stay on that longer, like 3-4 weeks, let her get acclimated, and then you go up again.
Okay.
Yeah, just take longer in between steps. Yes? Sorry.
question about medication because we have already known medications that have not worked, that the doctor should be talking to about having some type of surgery. If they haven't been talking to you about it, should you be concerned?
I wouldn't be concerned, but I would ask them, or just look for a level 4 center and just get another opinion, just to see if you are a candidate. So this happens a lot. We have neurologists who, we don't do the medications or take care of that specific stuff, but sometimes the neurologist says, hey, is my patient a candidate for surgery? We do the surgery evaluation, we talk to your neurologist, make sure everything looks okay, yes or no, and then go back. But it really depends on if there's a center near you that's comfortable doing surgery too. So I think that might play a part. Yes?
How do we sign up for trials?
Sure. If you go to the clinicaltrials.gov, so it's the NIH website, clinicaltrials.gov, and then you search keywords. So you could try epilepsy, but that's sometimes harder. You can, like LGS, or yeah, exactly. So Lennox-Gastaut, if you know the syndrome, search for that, and then you'll see medications that are available for recruitment. And you want to look for ones that say recruiting. The other way, just ask your physician, is there any clinical trials going on right now that you know of? Those are the two major ones. And then days like today, the Epilepsy Foundation, just to see if you're involved with LGS, ask the LGS Foundation, and they'll know the clinical trials. Yes?
You schedule an evaluation at UCLA
Yeah.
without a referral from the neurologist?
So if you would call the UCLA Center, see what they say. Sometimes they say you need a referral, and either you can ask them or the center can ask them. What other questions do we have? We have 10 minutes. I'm here longer time.
So I have a grandson that has autism,
Okay.
and he's an adult. He recently started passing out. Something totally new. Should he be checked?
Start passing out because of the seizures?
No, he doesn't have seizures.
Oh.
He just could go on a ride or do something different, and he passes out.
Pass out. Yeah, I would get evaluated for seizures. I would see what's going on.
His sister has seizures.
Okay.
Over here.
Yeah.
And is there a difference between, so we have a pediatric neurologist.
Yeah.
Is there a difference between that and the epileptologist?
So epileptologists is all we do is epilepsy. Peds neurologists they cover everything. So they could be really comfortable with epilepsy too. It just really depends on the doctor. So some peds neurologists treat headaches, autism, epilepsy, everything. So just because they're a peds neurologist doesn't mean they're not comfortable doing epilepsy. And if they're not, they usually recommend seeing like an epilepsy doc. So it really depends on the doctor. What other questions? Yes? Okay. Okay. What was the last sentence? There shouldn't be anything specific to make it not effective. So she had the epilepsy surgery, and was that effective or not? No, they resected part and it didn't help. Sometimes it's helpful to repeat the evaluation to see if there's any tissue left behind that needs to be cut out. So sometimes we do surgery, and then there's like a small part that's left behind, and that might be just all you need to kind of get rid of it. Or the small part that's left behind is something important like speech or memory, then the RNS device might be helpful there. But the VNS device is definitely a good option. Sure. Well, I'll be up here, but thank you everyone. It was a pleasure talking to you guys.